thanks to both Faith and Brian for setting this up. I really appreciate this opportunity to speak with all of you. And I was actually very interested looking at all the questions that are coming in. So thanks a lot for asking all those questions already. We really look forward to addressing them as soon as possible. So as both Brian and Faith have kind of set up, this is a complicated, lots of new terms kind of an area. But at the same time, you'll realize how both of them have done such an excellent job trying to parse it out and explain it, that it is so part and parcel of how we treat myeloma, these genetics. It becomes extremely important for every single patient to at least try and understand. And if for some reason they cannot understand, then reach out and ask. And that's, I congratulate all of you who are listening to this today that you're already taking that step and you're trying to take that step towards understanding your disease, understanding the care of myeloma, and kind of going from there. So let's start with some of these things. As we've talked about already, I'm not going to repeat all of the things that have been mentioned already, but there's this discussion about high-risk genetics and standard risk genetics. And as Faith went over these criteria, I think it's important for us to realize that these are two distinct categories, whether it is these high-risk genetic abnormalities with the translocation 414, 1416, 1420, deletion 17, gain of 1q, or a mutation in the p53 gene, or for example, as Faith just pointed out, these are not the only high-risk features. There could be other markers also. So we talked a little bit about gene expression profile. Mayo likes to do this plasma cell S phase, but also the revised ISS staging system. And then there are a bunch of standard risk disease. Okay, so I wanted to kind of put this out there. Some of the questions that are coming in are already asking, hey, I've been told I have 1q, or I think someone asked, well, 1q is present in about 40% or 40% of the newly diagnosed patients. Does that mean there is something significant about it? What am I supposed to know, or what am I supposed to do about it? So I think what I wanted to point out was this is a very good article which talks about what is the incidence or frequency of these abnormalities in patients who are newly diagnosed with myeloma. And to the best of our knowledge right now, what is the clinical implication? What is the adverse risk factor? What is a favorable, or what is neutral? So this is something that you can look at. But now when we say, for example, in the middle of this screen where it is hyperdiploidy, 50% favorable. What this means is that as compared to the adverse risk factors, as compared to the high risk factors, patients who have hyperdiploidy are more likely to respond to treatment or have a better outcome, have a superior outcome. So I was asked to talk about some specific populations and if there are any specific risk groups. Actually, I am noticing a lot of questions coming in. I'm just going to make sure. Yeah. So going back, so I was asked to talk about some specific populations. I focus a lot of my work in racial disparities, and with respect to myeloma also, myeloma genetics per se, there are quite a few racial variability and differences noted. So I'll touch upon that just briefly. There are lots of factors that can be taken into account when we talk about healthcare access and healthcare delivery. And we know that socioeconomic and cultural determinants of health are going to play a much bigger role than anything else. But there are some factors which I've highlighted right in the center of this figure, which is age, gender, and hereditary factors or certain genetics, which are beyond our control. So we can talk about the natural environment, we can talk about the health economics, we can talk about access to drugs, but there are some factors which are non-modifiable, for example, age, gender, and genetics. So when we look at this was a study back from 2013, which in my mind was probably the first one kind of talking a little bit more in detail about racial differences with myeloma genetics. And what this study showed was, there's lots of numbers, they cobbled together basically a lot of different data from a lot of different studies and showed that African Americans had a lower frequency of translocations, just like my previous colleagues mentioned, translocations where a part of the chromosome has cut off and gone and joined somewhere else, and then sometimes the portion from the second chromosome has gone to the first chromosome. So that kind of a balanced or unbalanced translocation. But it was shown that African Americans have a lower incidence of these translocations, lower frequency of these translocations, suggesting that African Americans may have a less aggressive version of myeloma. So genetically speaking, the myeloma of African Americans may actually be less aggressive. So those of us who are, for example, focused a lot on racial disparities and differences, we were like, oh, wow, that means that African Americans should actually be having better survival, superior survival. At that time, unfortunately, this was not being seen, but now, as of last year, there is one large study out of the VA, which is showing that if given the similar treatment opportunities, African Americans actually do have superior outcomes or survival, which kind of goes with this explanation that they have less aggressive disease. This was another study which was a little bit more sophisticated, had looking specifically at the TP53 gene, which, as was mentioned before, the TP53 gene, which is also considered or sometimes termed the guardian of the genome, because this is such an important gene to repair any kind of a damage that happens in our DNA naturally. So if this gene is mutated, the DNA is not able to repair itself. And those cancers that have this gene, because this gene can be mutated not only in myeloma, it could be mutated in lung cancer, it could be mutated in breast cancer. So whichever cancer has this particular mutation, that cancer tends to be more aggressive than its counterparts where this mutation is not seen. So what this particular study showed in a few years later, so in 2017, was that the TP53 gene mutation is seen less frequently in African Americans, again suggesting that African Americans have a slightly more favorable genetic profile. This was a study which was done by the Mayo Group and my colleagues up in Rochester. What they did was, well, we have cytogenetics in fish that come to the Mayo lab from across the world. So they just took samples that had already been studied and they tried to look at the ancestry or seeing if the patients had an African descent or a European descent. And what they found out was one of the things that showed up significant was that this translocation 1114 and also some other translocations were actually seen more frequently in African descent. Now you can say, you know what, you previously mentioned that the 2013 paper said that 14 translocations were less frequent in African Americans. What I can say is that that was putting together data from a lot of different databases, a lot of different setups. This is a little bit more refined, and what we are focused more on, I think, in today's myeloma age and beyond is that we are finally entering this world that we may have a biomarker-driven treatment. So for example, there are medications that are being developed which specifically seem to benefit the 1114 group. So I think in that sort of a setting, this 1114 information, for example, or newer information that may keep coming in this direction, that will be significantly beneficial. So one thing we can say is that deletion 17p is less frequent in African Americans and translocation 1114 is more frequent in African Americans. Right now, these are the ones that seem to be of most clinical significance, but the work is ongoing. Okay. So now, one of the things I wanted to reach out and kind of touch upon is, we've talked about what these translocations and deletions and hyperdiploidy, et cetera, are. But as I was looking at the questions, some people were saying, well, I've been told I have 3 copies of this particular chromosome translocation. Does that mean it's significant? Or somebody has said, I have a 2% of this particular fish abnormality. What does that mean? Does that mean it's significant or not? What am I supposed to do with it? Is it positive or not? I need a simple, straightforward answer. So to to preface those sort of questions, I want to take you through a study that we recently published, actually just last month. And what that study did was, the agenda for today's talk said variability in cytogenetics. Actually, what I wanted to talk about was variability in cytogenetic testing, because I think while it's important for each and every one of you and every single patient to know what these cytogenetics mean, it's also very important for you to know that when you're handed that report in your hands with, well, this is your FISH test, how am I supposed to interpret that? How am I supposed to say, well, these are the 3 things that came out significant and the rest is not? At least looking at that report, what can I say? So what we did was, for this particular study, actually before that, just a little bit of this has been covered already about what is conventional karyotyping, or how to, when Brian explained how is a cytogenetic abnormality detected, it could be done by conventional karyotyping, where all the chromosomes are lined up and any and every abnormality is picked up, versus a FISH test, where we're looking for specific abnormalities. So if we take a FISH a sample from the patient, a bone marrow sample, and then we start putting probes for specific abnormalities, for specifically, let's say 1114 or 1416 or 1420 or 17p or 13q or whatever. So whatever probes go in, only they will come back as positive or negative. So for example, if we use a probe for 13q deletion, that will not tell us anything about 17p. It will only tell us whether 13q deletion is present or not. So before doing FISH, for any disease, we need to know what are the abnormalities that we want to look for. It's also important to know the sensitivity of these tests is different. A karyotype, a conventional karyotype, counts on average 20 cells. FISH on an average counts about 200 cells, so a much more sensitive test. As I mentioned, karyotyping talks about the global changes in the chromosomes, while FISH is much more specific. Karyotyping is much more widespread availability, although we're seeing and we're thinking in terms of the FISH is giving us more clinically actionable and important information. But as a part of my work, I do also a lot of review of stuff that is happening outside of the US. So African countries, South America, India, and a lot of places FISH may not be available, still karyotyping is. Cost and time duration of doing the testing makes a difference. And also, and I guess this goes to one of the questions which was asked, I think my friend Jack from California, Jack Ayalo, he asked this question, well, how frequently should the testing be done? So we know, as Brian mentioned, that there is clonal evolution, so the disease can evolve. And some of these high-risk features can be acquired as time goes on. So what our practice is typically that while we may not run it on every single bone marrow biopsy because of cost and just what is the appropriate thing to do, but at baseline, everybody should get it, especially if the disease is not behaving clinically the way you want it to behave. So you were expecting it to respond to regimen XYZ. It did not. I think it's reasonable to see, oh, so did something change? Or if a disease has been quiet for years, a person has had smoldering myeloma for 10 years and now they have active myeloma, or the disease is progressing differently. It is showing up with many, many more plasmacytomas. Of course, if somebody has plasma cell leukemia. So if the clinical behavior is different than what we expect, I think it's very reasonable to check again. And then in between, whenever there is possibility, again, it should at least be discussed, well, do we need to keep checking FISH again and again or not? So talk to your physician. So as I mentioned, this particular study, which just got published, so basically we looked at more than 1,200 patient data, which including about a little more than 1,100 conventional karyotype and close to 1,000 FISH results over a span of about 18 years, tested across 58 different labs in the US. And what we noticed was that these were the number of samples that were tested at any given lab. So for example, there was on the left in panel A, it is showing the number of samples in lab number 1. By the way, we did not use any lab's name because we didn't want those centers to kind of feel offended. But at least we wanted to say that there is variability. So for example, on the left panel, That is talking about the conventional karyotype, the conventional cytogenetic testing. And there's one lab so there were actually 28 labs that only had tested one sample over a span of 18 years. On the other hand, there was one lab that had tested 8 samples. So the number of samples was very variable. Then we also checked the same thing about fish. There were labs which had only checked 1 or 2 samples, and there were labs which had tested many more samples when they were adjusted to and kind of per year. So very variable in the experience of the lab. We also looked at, this is looking at karyotyping. So again, conventional cytogenetics, interlab and intra-lab variability. I mentioned that the average number of cells counted is 20, but there were labs that were counting on an average less than 20 cells. And for some samples, less than 20 cells. For some samples, that same lab would count more than 20 cells. So the question becomes, okay, if somebody says you've got one plasma cell that was picked up, and that has this abnormality, what is the significance? Versus if 20 cells have the same abnormality, what is the significance? So generally, it is said that if there is a gain type abnormality, like a hyperdiploidy, etc., then you want to see that in 3 chromosomes to say that it is clonal, meaning that it is a true finding. And if you have a loss type abnormality, you want to see that in at least 2 chromosomes to say that that is true. So this came up as a difference in the lab handling. This was looking at fish testing. And again, rather than going through all the details, and this data is available publicly, that the number of probes used for fish, because I said that in fish testing, you need to know exactly what you're looking for. If you check for 3 abnormalities, you will only find out if those 3 are present or not. So the number of abnormalities tested across different labs was very variable. There were labs which were only testing for 1 abnormality, and there were labs that were testing for a slew of them. I can tell you, I previously trained or worked at USC in Los Angeles. USC used to send its cytogenetics and fish to City of Hope. City of Hope, just like Mayo Clinic, had an extensive panel. I mean, these sites would pick out such things where you're thinking, okay, what am I supposed to do with this information? There's so much information. But at the same time, there are labs that will only check for 2 or 3 abnormalities. Now, some of it may be cost saving. So for example, a lab may say, well, if there are 5 high-risk abnormalities, I'm going to only look for those 5 because it's cost effective. If those 5 are tested and are all negative, then genetically speaking, the myeloma is going to be lumped into standard risk. So that's important for you to know. I think as a bare minimum, those 5 high-risk myeloma abnormalities must be tested. Then we also found out that the exact probe that was used for a particular abnormality could be very variable. I've put in some examples here. So for example, 1114, 13, and 414. I'm just quoting 3 examples. We looked at many, many more. There were so many different probes that could be used. Now, one can say that, okay, if there are mutations or specific abnormalities, is it possible that one of these probes could miss? Or is it possible that one of these probes could overcall? I don't think we'll be able to sort all of this out in today's discussion, but I think this is where having that fish result and discussing with your doctor becomes extremely important so that you realize what that means and how it applies to your care. We also looked at, this is kind of trends over the years, and we looked at comparing the earlier years to now up to 2016, that the average number of probes being used by labs for testing in fish has been going up. So more and more probes are getting used. But like I said, in my mind, if it is push comes to shove, those 5 basic high-risk probes must be tested. Okay. So as my other colleagues have very nicely and conveniently said, okay, we're going to talk about treatment a little bit later. So I was thinking to myself, how would I fit treatment guidelines when we are talking about genetics? And our first goal, at least the way I look at it, is that everybody at least understands what genetics are. I'm going to leave you with some thoughts about treatment guidelines. This will not answer every single question you may have. And it may not be exactly what your doctor is doing for you. I don't want you to think that something wrong is being done in your case. I think we want as a community to spark that discussion so that you can take this information back to your doctor, have a discussion, be more informed about your disease so that we can, as a myeloma community, work and move towards curing myeloma. So this is, like I said, one of the examples, and this is what the Mayo Clinic guidelines are. Now, by the way, this has nothing to do with clinical trials. The way we have it set up is that all of us at Mayo, which is about 40 or so of us at the 3 Mayo sites who focus only on myeloma, every time a new study comes out, we look at our data and we say, okay, does that mean something should be changed? So this is, for example, saying one of the possibilities, one of the algorithms, is that patients who have standard risk myeloma, this is talking about newly diagnosed, and it is talking about transplant ineligible. And what it's saying is that if you have high risk myeloma, a combination of a proteasome inhibitor like bortezomib, an immunomodulatory drug like lenalidomide and dexamethasone, we should give that sort of a regimen for maybe close to 9 to 12 months, maybe closer to 12 months, and then we should continue towards progression, continue on maintenance till progression. If somebody has standard risk disease, and we've, for example, talked about 11-14, trisomies, etc., then it's still appropriate to start on that similar sort of a regimen. There's nothing wrong about it. And it's also very reasonable to consider other regimens, like we have daratumumab lendex that is also approved. So again, there is no reason to say that one is the absolute right choice for one category. But I can tell you, when we go through these discussions, it's a lot of discussion that happens amongst all of us and saying, well, this is what this study showed. This is what that study showed. So this is just one possibility I'm bringing up. Similarly, if it is newly diagnosed but now transplant eligible, then things are a little bit more complicated because we have to bring in the possibility of, for example, a stem cell transplant. Again, newly diagnosed, transplant eligible, this is one of the algorithms. By the way, MSMART or the Mayo stratification, it's available online, it's free. Anybody can go into msmart.org and you can access it. But standard risk with induction, transplant, and then maintenance. Similarly, high risk in the middle with the induction treatment, but it's very reasonable to consider even a 4-drug combination. Again, this has to be individualized. One size does not fit all. You've heard that time and again. And then if a person gets transplant, and then go on to maintenance. Similarly, there was this mention about double hit myeloma, triple hit, or very high risk myeloma, where you have someone has multiple of the high risk mutations. Then it's probably reasonable to consider again the 4-drug regimen potentially. Again, important to discuss. 3-drug regimen may be better for someone because if they don't tolerate 4 drugs, there's no point going down that road. Transplant and then maintenance. I did not even bring in relapsed here because I think in the relapsed setting, more so than genetics, a lot of other factors go into the mix. For example, how did the person respond to the frontline treatment? So let's say if someone has deletion 17p, but they've responded beautifully and now their disease is in control for the past 3 years. Yeah, that genetics of myeloma is playing less of a role. And maybe if that person has severe kidney function, is on dialysis, maybe that has a bigger role to play in the choice of next treatment. On the other hand, we all of us who focus on myeloma, we have patients who don't have any high-risk features, but they start on treatment and 6 months later, they're already progressing. They get a transplant and 3 months later, they're progressing. So genetics or not, that myeloma is telling us that it's clinically a much more aggressive clone. So I think, especially in the relapse setting, a lot other factors have to go into the mix. So what I want to basically end by is saying that genetic testing in myeloma is considered a standard of care. Not everybody may need a myeloma genomic panel or next generation sequencing right at the outset, but at least basic simple FISH and or karyotype should be done every single time a new myeloma is diagnosed. Cytogenetic testing, as I said, with FISH or karyotype is most widely used and is available and is of very important clinical significance. There is variability in testing techniques, but more attention is being paid to that now, and hopefully we'll have more standardized guidelines, but I want everybody to consider taking that report and talking to your doctors. Cytogenetic testing must be used to make the treatment decisions. As I said, high risk and standard risk, we already said one size does not fit all, but especially for high and standard risk, that absolutely does not fit the same bill. And then novel techniques will hopefully improve our understanding of myeloma biology and also how treatment decisions are taken in the future. So while, like Brian and Faith mentioned, that we may not be taking a sample and doing a gene expression profiling and channeling the patients to say, hey, you get bortezomib, you get len, you get VRD, you get KRD, you get DARA, et cetera. We're not doing that yet. But the technology is present and those processes are getting validated right now. So the future is brighter and much more hopeful than what we have seen so far. Thanks a lot. And I'm going to stop sharing my screen and bring everybody else on now.